Just continuing some of the topics from last week, I do have some questions that we didn't get to, so hopefully I'll get to those during our Q&A session. We continue to support our colleagues at the jail, which is experiencing a rather large outbreak, and we will definitely have some updates about the numbers as well as the intensity of those cases once we touch base with them, and so that's still going on. We're also working more closely with the California Department of Correctionals, which is the CDCR, and that is a process that I welcome just because I think the collaboration and the communication will really help take care of inmates, those who are being released, as well as the staff and the medical personnel who work with this vulnerable population. So the CDCR, the county, as well as other regional bodies are working together to make sure that there's really good communication about who's being tested, when people are getting released, making sure that they have contact tracing as well as housing services ready for them whenever they get released. All of that I think is going to be very valuable and hopefully will serve all of us to safeguard the health of the public during this challenging time with our congregate living in our congregate population, such as our jailed population. We are also very busy with working through a lot of the ramifications of the statewide mandates that were announced last week. And that includes really amending or closing a lot of the way business operations have run. And really the philosophy of these mandates was really predicated on the fact that we have so many cases that are being experienced statewide. This really bodes ill for our medical capacity to be able to take care of the sickest cohort of coronavirus patients at the same time that we take care of all of the other non-COVID illnesses in our medical facilities. So the point of the mandate was to make sure that we decrease the risk in a lot of the business and social activities that are currently being permitted in our society. And for many people, that meant having to close down their venues just because they weren't able to mitigate the risk to the satisfaction of what the governor's office and what the State Department of Public Health wanted to see. For others, it meant making some transitions and making sure that that things were done outdoors as much as possible, including restaurants and other businesses such as restaurants that could offer outdoor dining experiences. Those are the kinds of changes that were mandated by the announcement last week. We're still working through the implications of that. And my team with environmental health, our director, Dave Palmaville, and myself have been in communication with the Occupational Safety and Health Administration, OSHA, as well as some of the statewide labor department, as well as the ABC Commission, which they're all really wanting to make sure that people are behaving as safely as possible, and also supporting and answering any questions that they can about how these mandates were announced. So that's requiring a lot of dialogue. On our end, we're doing as much homework as we can to figure out exactly how we can support businesses so that they can possibly stay open. But at this time, we understand that there are some transitions that are required as of the health officer order that was signed last week. And we do expect that the industry will hopefully be able to comply with the requirements of that order. We had some meetings over the weekend with our hospital partners just to continue the conversation and to make sure that we understood what their needs were, what their challenges were, and really what resources we could all bring to bear to support, like I said, the sickest of the patients that developed the coronavirus. I had the opportunity to work on the 4th of July in the emergency department, and I saw just a handful of coronavirus patients. Thankfully, the ones that I saw were relatively well because I was working in one of the lower acuity areas. And at the same time, it's pretty evident working on the front lines of medicine here in Fresno County that we are experiencing a higher level of volumes related to coronavirus. And at the same time, our hospitals have some serious capacity issues and staffing issues that we are working through. And so even though we feel that we are currently able to take care of everyone who's coming in, this is a really critical time, and we need to all do whatever we can, whether we're in the medical field or not, in order to decrease the numbers of transmissions that we are experiencing here in our county. That's why the safety messages related to staying outdoors, staying apart, staying masked, and keeping your hands clean, staying clean, are so important during this time. This is really a critical phase of the pandemic, and I know that a lot of these messages are somewhat tiresome for us to be messaging about, but they are really important. They're very basic, low-cost, economical things that we could do in order to really preserve what we truly value in our society, which is access to great healthcare, access to really communities that can stay safe and keep functioning, even if it is at a different level. And that's really, I think, what everyone's goal is. And although we may have different opinions about exactly how to achieve those goals, I don't think anyone can doubt that all of us want all of our friends and neighbors and communities to be as healthy as possible, because that way we are sure that that we really can get through this pandemic with a minimum number of morbidity and mortality. Let me switch gears and just address a couple of questions that I think are still relevant from last week, and hopefully open it up to any questions that you might have about any developments over the weekend. So this is a great question from Marie Edinger. If a patient tests positive a second or third or fourth time, do those extra tests get added to the total number of tests? Well, so yeah, that's a great question. What the data team does, and what takes a little while, is to make absolutely sure that each positive test is only counted once, and that does take some manual checking on different databases. But our team does make sure that we exclude any repeat positive tests that are done because we don't want to overcount the number of positives. Along those same lines, we had another question that said, if they get multiple negative tests, does that add to the overall number of negative tests that are done? And the answer is yes, because a negative test is really a snapshot in time that person is currently not having the evidence of infection at the time that they had the swab. But a week later, they may have either developed symptoms, or they may have had another high-risk exposure, which warrants another test being done. And if that second test is also negative, then we would still count that as a negative test. So in terms of the overall number of tests being done, we do count all of the tests. However, whenever the test comes back positive, we only count that positive one time. So hopefully that makes sense. I really can't do justice to the amazing data handling that's done by our epidemiology team. So I won't try. I'll leave it at that, and I'll let Dr. Kokumar answer any further follow-up questions that you have about that. I think that's all of the questions from last week that that we need to answer, but I'm sure if we open up the lines, that there's lots of fresh new questions that people might have. So go ahead.
Hey, Dr. Vora, it's David Talbot, GVWire. Once again, thank you so much for giving us your time today. Dave Fansler, the owner of some restaurants here in town, wrote a letter to Mr. Palmaville. I guess he's complaining that certain enforcement for his restaurants, well, maybe not enforcement of others. Just wondering a clarification about your view of the open window plan that he's talking about, and maybe Mr. Palmaville, if he's on the line, can address the letter he posted on Facebook.
Yeah, Dave, I think he's on another call right this minute. But yeah, we've been in communication with Dave Fansler and also with the other agencies that are involved. We're asking for clarification, but as it stands now, the open windows would not be enough to consider that outdoor dining. And I know that that's a somewhat controversial statement, but as it stands, it's still considered indoor dining with open windows. And as the mandate from the state requires, that would not be permitted. So we'll follow up with that and definitely offer clarification. But that's kind of where the issue currently stands.
Dr. Vora, it's Jocelyn with KC24. I just had a question with hospitalizations. I appreciated the chief medical officers on Thursday speaking on the situations in our hospitals. I just looked at the state data, and I know it says in Fresno County there are 163 patients with COVID-19 or suspected of having it hospitalized and 40 in the ICU. Yes. I was just wondering, in just the last couple of days, what have conversations been like between the health department and local hospitals, and are these numbers continuing to increase?
Yeah, thanks for asking, Jocelyn. Indeed, the numbers are continuing to increase. At CRMC, I think you heard Dr. Thomas say that that he would be paying attention to when they cross the 100 threshold, meaning that there's 100 patients hospitalized collectively at the community medical centers, and that indeed has happened. And beyond that, the other hospitals are also seeing an increased number in terms of their census of hospitalized patients. So that's where the 163 comes from. And that doesn't include another 40 or so, which are considered suspected. So overall, we may have up to 200 patients who are hospitalized in and out of the ICU within the county. And that is a number that just keeps rising. So that is something that we are concerned about. When it comes to the type of dialogue that we're having, we really just want to make sure that we understand what the hospitals need and really where they're getting their resources so that we can make sure that we can support those supply lines. Sometimes it's a medication issue. So we're trying to support their request for the different kinds of medications that may be short during this time. But really the larger challenge is a staffing issue. And that's something that the hospitals themselves are being very aggressive about addressing. And I won't speak for them. I think they've been very open about some of those issues and how they're tackling them. But I will add that the staffing issue is something that we ourselves here at the Public Health Department are also contending with, because we have up to 250 beds at the Fresno Convention Center as part of our alternate care site. And we have protocols that we've fleshed out in terms of how they could be used, the types of patients that could be properly taken care of there, and really the ratio, as it's called, of doctors to physician's assistants to nurses to licensed vocational nurses and other staff. So we have all those ratios planned out, but going out and finding people to actually staff that convention center is another matter. And we really feel like at the same time that we will need that convention center staffed, that all of these professionals will also be requested or forced to work at really all around the hospitals in our county and perhaps in our Central Valley. And so that is something that we are actively thinking through is, where can we request external resources? Because we really don't want to poach people from the hospitals to work at the convention center. That doesn't really make much sense. But we also understand that by the time we need to open up the convention center, that the hospitals themselves will be at full capacity and will be using all hands on deck. And so we need to probably request from the state, and my EMS division has already communicated with the state that this is where we are right now, as well as getting creative with outside agencies such as volunteer corps agencies and even other sort of humanitarian kind of agencies that might come help if we needed them right away. So we are taking a stepwise approach. Like I said, we don't want to act in a vacuum. We want to act in coordination with all of the other hospitals. And I think the communication and dialogue that you heard last Friday just shows what kind of superb coordination there is in this county and how much commitment there is across the leadership of all the different hospitals to work together. So that's very heartening to be working in this space. But we know that we're all in it together and that we all need to solve these problems together. But that's kind of where we are in terms of the types of conversations that we have with the hospitals.
Dr. Vora?
And I'll just add one more thing. We just share best practices. I will humbly submit that I have a lot more to learn about coronavirus just how to treat it in the ICU, how some of the clinical literature should be interpreted. And I think all of us that are working in medicine, regardless of if we're physicians or non-physicians, we're all just trying to learn the best science so that we can apply it for our patients and save as many lives as possible. And so really a lot of the conversations that we're having are about, okay, when do we start using this medication called remdesivir? When can we start using medication called steroids, which are now showing a little bit more promise? Who requires or who gets the heart-lung bypass, which is the ECMO. So we have world-class experts throughout the Central Valley that can help us work through those issues. And we really try to facilitate dialogue by having a weekly call for medical providers where we can sort of answer and ask these sorts of questions in a professional way. And really, we just try to touch base almost every single day with our hospital partners and our medical partners out in the primary care side to make sure that information gaps are filled as soon as they're created.
Hi, Dr. Vora.
Hi.
Vic Bedoyan from KFCF Radio.
Hi, Vic.
Hi. And I must say, before I ask my question, I really like the billboards around town with with a great message, and you're becoming quite the local celebrity. So, which is a good thing.
Well,
it's a good thing.
It's a surreal time, but I'm trying to do the best that I can. Thank you. I'm humbled by that.
I'm concerned about the Fresno County Jail. I know there's a high level of concern by a lot of people in the community. There have been demonstrations and so forth. And I'm wondering, what are conditions like in the Fresno County Jail? And is this an appropriate place for someone with COVID-19 to be recuperating? And might there be a better way to handle that? Could you talk about that a little bit?
Yeah, sure. Great question, Vic. It is concerning to hear that we have an outbreak affecting hundreds of inmates at the jail. I do think that the amount of planning and preparation that has been done is helping us in terms of the response that we're having. We have a team here at Public Health that confers with and works with the medical team over at the jail. And of course, we're actively working with the sheriff's office, which oversees the operations at the jail. And all of these agencies are really working together. And we have been for many months. Part of the original intent of the $0 bail policy was to make sure that there was space cleared out in the jail so that we could create really places where people could quarantine safely, perhaps away from other inmates if they themselves were at high risk or diagnosed with COVID. And so that was already done. And in fact, hundreds of inmates were actually decarcerated in order to make that space. So I think that, certainly it is concerning. It is warranting and getting the full attention of the staff involved. But it is a crowded spot. I mean, there's no two ways about it. And masks are being distributed, masks are being used, and I think that does help mitigate the spread of the virus. And at the same time, the jail medical staff is being very attentive to make sure that people get their medications, people get their medical illnesses taken care of that are not related to COVID. But then also people get vital signs whenever they are diagnosed with COVID so that we can pick up on things like complications related to viral pneumonia. Sometimes if the oxygen level starts to go down, then those inmates are immediately transferred to get a higher level of care and to get a more full workup done. And so I think that it's working pretty well. I think that, certainly I sympathize very deeply with the families of all of those involved, both the inmates as well as the medical staff, as well as the sheriff's office staff who are now having to contend with this pandemic during a very challenging time. And so we're trying to support them as best as we can. But I do think that there's many layers of protection and many layers of response that have at this point been introduced. The one that we've most recently introduced is testing, and really aggressive testing. And I think that will also pay dividends. It may take a couple of weeks for us to get to where we need to be, but really our plan is to make sure that everybody who needs a test gets a test every week, whether that's one of the sheriff's office staff, one of the inmates in the jail, one of the medical staff, And that will just make sure that we really get a hold of this outbreak and really understand what's going on, especially those that are not currently affected. We want to make sure that we try to prevent the infection as much as we can. And if there is, someone who gets newly infected, that they have the space to quarantine and they have the masks that they need to keep it from getting spread to other people. So I think that there's a lot of strategies that are being deployed. We had a really productive conversation with the prison law office last week. We plan to continue the dialogue to make sure that they have all their questions answered. And really, if there's any families or other advocates that would like to talk to us to get more questions answered, I'm more than happy to speak with them. I'm really very proud of really how our medical partners at the jail have been responding to this pandemic. I think that they've been doing things very evidence-based. They've been very sensitive to the needs of the incarcerated population, and we're just hoping for the best. Fortunately, the vast majority of the inmates are not experiencing severe complications. So even though they have the coronavirus, they're not requiring hospitalization, but they're not out of the woods, and we understand that, and we want to make absolutely sure that they get the oversight and the monitoring that they need to make sure that they recover uneventfully.
Hi, Doctor. I'm Natalie with Univision. Can you please explain the difference as far as risk levels for different activities? For example, with the recent restrictions for singing at a church, I've seen people wondering, well, how is this different from chanting at a protest, for example?
Yeah, good question. I think the most obvious difference is that one is indoors and the other one is outdoors. I think beyond that, they are very similar. In fact, anytime you're really raising your voice above a normal speaking voice, or just breathing really hard, even using musical instruments that require you to breathe really hard, then you're basically increasing your airflow. And the concern there is that if a person is infected with coronavirus, if they increase their airflow, if their diaphragm really starts pumping like a bellows, that it's really going to start pushing out those droplets at an increased velocity, and really that's going to spread very far. So that's where the 6-foot rule may not actually be protective enough, and you may need to be 20 feet away from someone who is singing. Really, there's been some well-done studies from the Centers for Disease Control and Prevention that have been published that show that singing can actually spread even if people are doing social distancing. Just the act of singing, because it's usually done without a mask, can actually spread droplets and perhaps create aerosols that would stick around even longer than droplets. So that's why it's considered a more high-risk activity. But yeah, totally agree. Chanting is as well, whether it's at a protest or outdoors. And so whenever you're participating in any of those activities, you really have a responsibility to yourself and to those around you to make sure that you're doing it as safely as possible, and to wear a mask if you can. This is where some of the science is not as complete as I would like it to be, because I always wonder about the plastic masks. I mean, we've all seen those. I mean, the plastic shields. We've all seen those. Unfortunately, the science hasn't really caught up to say, how beneficial are those plastic shields? I think that if they are found to really block a lot of the droplets, that maybe that would be a solution that would allow us to, do some of these activities like singing, chanting, etc., and feel a little bit safer about our risk of transmitting this virus to other people. Obviously, it's not totally airtight. And so things could still get out, especially aerosols as opposed to droplets. But I don't think that the science has really answered all those questions to a degree that those of us who are doing medicine find satisfactory. So I'm really hoping that that's where the scientists will focus their efforts, is to figure out, how do the plastic shields help protect us, especially if they're combined with masks like cloth masks, because those might actually be a good answer to let us do some of these activities that I know all of us enjoy doing.
Thank you.
Dr. Vorha, it's Liz Gonzalez with Fox 26 News. Thank you again for your time. We got messages from a couple of viewers asking regarding Fresno County's recovery rates. According to the dashboard, you guys have Fresno County has a 22% recovery rate. However, having done the math, I'm looking at other counties in the valley like Tulare, which is showing a 66% recovery rate, Madera a 58%, Merced is above 40. What is keeping Fresno County's recovery rate so low?
Yeah, that's a great question. Thank you, Liz. I think there's a couple of factors, and unfortunately, my data team isn't here yet. So the way that they count recoveries are really related to the level of follow-up that we can do. It's not always related to negative testing at the end of somebody's period of illness. It's really how well we can follow up and make absolutely sure that that person did recover. Unfortunately, with the way contact tracing is done, it's usually based over the phone. That's not always a successful method of following up. And so we don't always have complete data related to that. So I know that some of that data, the 20% seems low, and I agree with you. And I think that that might be related to the fact that the follow-up isn't where we would like it to be in terms of our contact tracing. And the other factor is, that there's the definition of recovered is that the person has to be 3 days without symptoms at the time that we talk to them. And so unless we actually have a conversation with them and we can document that that's what's going on, we're not able to consider them recovered. It's not a perfect metric, and I totally admit that. I think that more work could be done among our medical community as well as among our general community. And here at Public Health, we are actually looking very hard at ways that we can get that metric a little bit more precise, including using things that aren't phone-based, such as an app, for example, or a website that people can log into, or even email that they can actually get back to us when it's convenient to them and let us know how things are going.
Does some of it boil down to I'm sorry to interrupt you. Does some of it boil down to a staffing issue, or is there also a language barrier?
Both. So I think part of it is the language barrier leads to a staffing issue because if you have, inefficient communication or it requires multiple different translators on the phone, then obviously that ties up a lot of staff. But we're actively trying to address that. We've onboarded many contact tracers over the last few weeks, and we're hoping that this new partnership with the city of Fresno also allows us to train up a few dozen contact tracers that are going to be community-based and really help us reach out into communities where culture might be a barrier, language might be a barrier. Just this paradigm of having a government agency call you and ask you very personal questions. It strikes some people as a little strange. In fact, probably all of us would be kind of dumbfounded if we got multiple phone calls from government agencies asking us about personal health information. It's really just not a paradigm that people are used to. And I understand that, I'm sensitive to that. But it does lead to a lot of drop calls, a lot of unsuccessful contacts that unfortunately, the recovery rate is one of the casualties of that missed connection. But moreover, the ability for us to really give good information and have people get the support and the information that they need to make good decisions, that's probably the larger casualty. And I think that that's what's driving some of the increased transmission.
Thank you.
Thank you.
Dr. Vora, this is Tim with the Bee. How are you?
Hi, Tim. Doing well. Thanks.
Good. Couple of real quick questions. The answers may not be quick, but the questions will be. Where are we at in terms of additional testing sites and testing capacity and meeting one of those metrics that the state has asked us to do, that 1,500 per day? Second question involves schools, higher education, and returning to campus. I know Fresno State and Fresno City College have both said they're going to be primarily online. Fresno Pacific University, a much smaller school, is aiming at returning to the classroom to the extent that they can. Any thoughts with regard to the advisability of bringing students back to a classroom, whether it's higher ed or K-12?
Yeah, thanks, Tim. Those are great questions. In terms of our testing capacity, so the metric that the state wanted was to have between 1 to 2 tests per 1,000 residents, which in our county translates to between 1,000 and 2,000 tests. Just for just for convenience sake, let's call that 1,500 tests a day. I think we're hitting that mark on many days, maybe not every day, but we are hitting that mark on many days at this point, which is very reassuring. So I think we've not only built the capacity, but we're actually following through and getting those tests done. We still haven't given up on getting a fourth site. So we're actually exploring ways that we can get a fourth site in rural county of West Fresno. And we're hoping that that actually helps to address a lot of the needs that our rural populations are still currently facing, despite the fact that our testing has gone way up. So I feel comfortable that we are meeting that metric for the most part in terms of the total number of tests that are done. The positivity rate still stays high, is still staying high. And so that's something that we all need to work on, is to get the number of positive tests below. Really, the state wants 8%, but I would love to have, under 5%, just to make absolutely sure that we have that cushion built in, just in case we have, a sudden unforeseen surge, for example, later on down the line. And so the positivity rate is something that we do need to work on in terms of the state's metrics for getting us off of the targeted engagement list. But the actual number of total tests being done in the county, I think that we've at last, really through the hard work of Dave Palmaville and the rest of my testing team, we've at last met that metric that the state wants us to see. Your second question about schools and colleges, again, a great question, a very large question. I think we're in uncharted waters here. And so, there's really no, I think there's no template or cookbook that's going to apply, across all institutions. I think that people will need to craft solutions that make sense for the population that they serve. We're working very closely with the K through 12 schools and making sure that they have good information about how to keep kids safe, how to keep teachers safe and staff safe. And that includes, best practices that are at this point shared by CDC, as well as the California Department of Public Health and the Department of Education. The clicker, though, is that not all of those practices align. And so what we're having to do is to really go through and decide which sets of recommendations seems to make the most sense. Some are more restrictive than others. Some are, recommending just different models of schooling in terms of when to bring kids back, how many to have in a classroom together, whether to do alternate days, et cetera, et cetera. Again, no one has the benefit of I guess, hindsight with this problem. We all are just trying to, move forward, knowing that no one has done this before. We understand that based on the science of the coronavirus, that masks are a great idea, that the social distancing is a great idea, that hand hygiene is something that will be a definite requirement. Beyond that, in terms of how many kids to have in the classroom, it just depends on the size of the class. And I think that applies for the colleges and universities as well. So that's why the smaller universities and colleges may opt to have smaller class sizes and in-person gatherings, whereas larger campuses may just not have enough space and logistical resources to make that happen. And so going online seems to be a good idea for them. So again, I think it makes sense for every campus to really craft their own solutions. And that applies, starting at kindergarten onwards. I think it also makes sense to just plan ahead and say it's not a matter of if, but when you're going to have coronavirus in the classroom. And what are you going to do? We just know that, asymptomatic spread and asymptomatic infection is just a fact. It does happen. And so whenever somebody shows up and then 2 days later, it becomes evident that they had coronavirus at the time that they were in class, whether that's a teacher or a pupil, you have to have a plan in place. And that's really what the big takeaway that we're trying to impart to all of our partners in education is to say, look, as long as you have a plan in place, this is not going to necessarily warrant shutting down the whole school. That as long as you have social distancing and masks in place, that you really are minimizing the risk to other pupils from, say, a student, for example. It could also be a teacher, but really there are ways to minimize the ramifications of having a positive case within your facility. You just have to think through that. You have to be very transparent and open about the possibility that that could happen. I've advised some of our schools to just have a whole packet of communications. That way, parents, teachers, and staff are all on the same page about deploying these resources as needed. To say, on the first day of school, really send home a letter and say, "Hi, parents, thank you so much for enrolling your kids in our school. And here's our plan. Here's how we're keeping everybody safe. And here's what you can expect if there is a coronavirus infection that's found in one of our staff or in one of our pupils. Here's what our plan will be." That way everybody's on the same page. I mean, coming from the medical background, we drill and we really practice for different scenarios all the time. And this is really a time when our schools are going to be drilling and practicing for this scenario, which is going to be an inevitability sometime, somewhere. You're going to have this situation come up. And so that's what I would advise, is to make sure that we've thought through all of the contingencies and make sure that we have all of the tools and the screening and the monitoring in place to minimize the number of people affected. Because if it turns out that we did no preparation whatsoever and we flooded everybody to go back to school with no changes made at all, then that will really cost a lot in terms of what's going to happen whenever an infection is discovered within that facility. Then we're really going to have to quarantine a lot more people and possibly even shut down classrooms or schools. Obviously, nobody wants that. That would be very disruptive. And so I think putting in the time to do this homework now will really pay off later whenever we do have those sporadic cases, as we know that we will throughout this fall and possibly into next year.
Thank you very much.
You're welcome.
Dr. Bourne,
go ahead. Sorry.
Ari, just to follow up on the testing, I've just heard of people going to get tested and them talking about the swabs just not going all the way up your nose. And I was just wondering if that's a new form that people are doing. Maybe yes. More people are going to be more willing to get tested if they know that.
Yeah, so this is changing somewhat too. And something that I just emailed my team this morning to say, where are we with this? It turns out that, the old standby for doing this testing was to use a rather long Q-tip and really going way in the back. That's called a nasopharyngeal swab, and really just tickling the very, very back of somebody's nasal cavity just to get some tissue so that we could test for this virus using that specimen. Well, it turns out that newer protocols are now allowing us to do a little bit more superficial, I guess, not as deep poking in terms of getting that tissue specimen. And so that we call that anterior nasal, which means the front of the nose swabbing. So some people may get one type of protocol, some people may get another type of protocol. That's what may trigger the kind of comment that you mentioned. We think that they're both equivalent, especially when someone's symptomatic. All of that tissue throughout your nasal cavity is potentially infected at the time that you have coronavirus. And so really just going along anywhere in there, as long as you get a good specimen, which is really more about the time spent inside the nose and not necessarily where, really just making sure that someone is swabbing correctly involves really the technique of making sure that they really get a good specimen, no matter whether they're using a long Q-tip or a short Q-tip. And I'll end with the observation that some labs are actually doing oral swabs, which look at saliva or even just some of the tissues in the back of your throat through the oral cavity. And to me, that's something that we do all the time with things like, strep pneumonia or, strep throat, things like that, we actually do oral swabbing. So now we have 3 different options. The science hasn't really made a determination of which one is the totally best option. The old standby, like I said, was the really big Q-tip that went all the way back in the back of your nose. That's really what most of the swab kits that are right now in circulation are relying on. And so that's most likely what you can expect when you get tested. However, more and more of our primary care clinic partners and even some of our Optum Serve sites and CVS are now doing the anterior nose swab. And we may even switch over to the salivary swab if it turns out that functions just as well. We just want the best test so that we don't have to test people again and that we can give them the most reliable answer about whether they have coronavirus or not. And so we just need to make absolutely sure before we make any big switches in our protocol that we're making the right move. So that's where we do hear these stories that different people are getting different types of swabs. I would say right now, if you're feeling symptomatic, go ahead and isolate regardless of what your test shows, or even before your test comes back positive. Because if you're feeling symptomatic, regardless of what your test shows, we're going to recommend that you isolate until you feel better. And then, hopefully we can choose the strategy which is the least invasive, the most comfortable, and also the one that patients prefer the most. So that's kind of how we think about testing, is we really try to balance, okay, what resources do we have on hand? What PPE will be required? Can the patient maybe even do this themselves? So we sometimes actually are able to have the patient self-swab, which is not really possible with the really long Q-tips. That's just impossible to self-swab yourself safely. However, if it's something that's the anterior nasal or the oral, that's something where a patient could possibly self-swab. So people are looking at that as well. And that would save us a lot of PPE. That would give people a lot more control about this procedure, which we think will be welcome by our patients. So these are all kind of, questions that we're working through. We haven't really landed on a specific protocol that works every single time for every single person. We just want to, again, keep everyone apprised about what we're doing, but at the same time, look at the evidence and make sure that the evidence supports that this is actually the best way to do this test.
Thank you.
Doctor, with regard to that, what are we looking at in terms of follow-up time, or not follow-up time, but turnaround time from swab to result? Is that getting any better, or is that still a couple of days?
It's still a couple of days. Yes, it is getting better, but it's not optimal. We really just need a 5-minute test. And unfortunately, we don't have that. I think that going back to the school's question, just imagine the decision-making you could do if you had a 5-minute test. You could literally just figure out, if somebody could play sports that day or go to school that day, just very, very quickly. And obviously it would revolutionize our medical triage procedures. So until we have that, we won't be satisfied. Some of our tests are coming back on the order of several hours. And those are not in large supply, but in short supply in our hospitals. And those are being reserved for really our most critically ill patients that absolutely we need to have that answer right away. And so sometimes we can get a test result back in as short as 8 hours. But most typically it takes 2 to 3 days. And some of the nightmare scenarios, which we're still hearing about, are when it takes 5 days or 7 days, because by then, unless the person has absolutely just gone into hiding, chances are that they've been out and about just doing their errands, and hopefully they've worn a mask. But if they haven't, then they've passed it on to the next person even before they themselves get the diagnosis. And we think that that's actually driving a big part of the transmission at this stage.
Dr. Vorha, piggybacking on that last question, what is being done? It's Liz with Fox 26 again. What is being done to increase lab capacities? I've heard of other neighboring counties entering into more public-private partnerships. What is Fresno County doing, since we need to increase the number of tests? That obviously is going to mean we need more capacities when it comes to processing those.
Yeah, so great question. This is part of our relentless pursuit, is we're always talking to new partners and new potential partners. Our major labs that we have here in town include Quest and LabCorp, and then the in-house labs that some of the hospitals are offering are actually doing a lot of the testing at this point. Not all of it, but a fair amount. There's also a lot of new startups that are now coming on the scene, and we're trying to make sure that we can quality control those. But we think that they may actually be promising partners for us. None of them that I know of are based here locally, so it would still be a send out, and that would confer kind of a turnaround time of 24 hours or so just to get the specimen mailed to a different part of California or even a different state, and then to have the result electronically relayed back to us. But it is something that we're actively pursuing. Another great partner that I want to mention is the Ucsf Bio Hub. So that's actually located in San Francisco at their main campus, and they have been a great partner with us from the very beginning. They've been able to run a lot of specimens for us with our rural surveillance testing. They've offered to help us with our baseline testing in our jail population, and I think that they're also going to help with the with a really big project that the city of Fresno is helping to support at UCSF Fresno. The UCSF Bio Hub is really going to be, I think, a key player for us here in Fresno County. But beyond that, yeah, it's a real patchwork of different types of labs, types of tests that we're able to get. And we continue to try to make progress as best as we can. This is one of those situations, though, where it's kind of like when you're standing in line at the grocery store and then you see that there's like another checkout, and then everybody rushes to that line, and then that line becomes the longest line. And so basically, this is where we are with the testing is, as soon as we find out that there's a lab that offers a really great turnaround time, a really great service, almost everybody lines up to use that lab. And then lo and behold, their turnaround time and their ability to serve all of their consumers actually deteriorates a little bit. And so it's just a matter of spreading out the work and making sure that we use all of the resources that we can, and not just one or two labs that then have the burden of having to run every test in the county. So we have to be smart about the resources that we deploy, but I think we are making progress. Like I told Tim, we've been able to meet that metric of 1,500 tests a day for many, many days now, almost 10 days. And I think that if we keep going with that, that will really serve us well as we enter this later phase of the pandemic, where we need to be doing a lot more baseline surveillance and testing all over the county.
Thank you.
You're welcome.
Dr. Bora, this is Maria from Radio Bilingüe. On the testing, it seems like at some of the private insurers, they are insistent that they would only test someone who's symptomatic. And sometimes people might be in contact with someone who later tests positive, and they want to make sure that they're okay or that they're not asymptomatic, but
yes,
they're facing, a little bit of a barrier there
yes,
for testing. So, wouldn't it be better to test anyone who's interested, even for the comparison?
Yeah, that's a great question. Thank you, Maria. There's several different factors that go into that kind of situation. From the level of the provider, they're only given a certain number of tests, and so if they use them all up, then I think that there is that legitimate concern that once their tests are used up, that in through their door will walk a symptomatic family, and then they won't be able to test them. And so I think that there is some wisdom to reserving the symptomatic testing whenever you have limited numbers of test kits available at your site. And so that's where I think that rationale comes in, where some of our providers are not testing everyone. They're only testing the symptomatic people. The insurance issue is a different issue. I can't really speak very eloquently about that other than to say, this should not be a barrier. It's just, it does present a barrier because I think that more paperwork needs to be done. But even an asymptomatic uninsured person is able to get a test in Fresno County. That's really how the state has set up these OptumServe sites. And that may just translate into having the person go to the OptumServe site. That is considered a low barrier, anyone can get tested kind of a situation. And so that's kind of what those sites are designed to do, is to catch people at a time when they're not symptomatic. Maybe they just have a close contact and they want to get checked. That's what those sites are set up to do, is to serve that population. With other primary care doctors and other clinics, we don't really supervise or approve testing. We do put out best practice protocols, and we have advised to, whenever you have limited capacity, to try to triage and prioritize the people that are at highest risk. Doesn't always mean that they're symptomatic. It might mean that they are first responders, working in law enforcement, working on the front lines of medicine, working in a public service sector where potentially they could spread the infection to many other people because they deal with public service. Those are the people that do need to get tested, even if they're asymptomatic. And so whenever we set out our testing priorities, we do prioritize those folks at the very top. I know it doesn't always seem fair, but that seems to be the most rational way to distribute the testing whenever the capacity is limited. But like I said, the capacity has gotten so much better that no one really should feel that they can't get a test because they're asymptomatic. They may just be forced to go to a different site, like one of our Optum Serve sites, in order to get their testing done, just because they didn't qualify for that specific clinic's criteria.
Thank you.
Thank you, Maria. I think we have just one more announcement, and then I see Rich Lembo is on, so I'll let him talk about his the developments with their contact tracing app that they've developed. The update that we have is that our dashboard reports were updated this morning. So this is not necessarily the case counts, but it is some additional information related to surveillance and the mortality review. So if you want to look at the trends related to that, like I said, Dr. Kokumar, our senior epidemiologist, will be on our media call on Wednesday at 4 p.m. So please take a look at the reports that are released on the dashboard. I'm told that we're going to be releasing some geographical data as well. That's a little bit more granular than what we have released already. So hopefully that will help answer some of your questions if you have them about where exactly cases are being localized to in terms of our Fresno County as it's laid out. But we'll have Dr. K explaining her team's work and really the hard work that they're doing to make sure that we all have good data to make decisions with. And with that, I don't know if Richard, you're on. Sorry to put you on the spot, but that's one of my favorite hobbies during this pandemic is calling on you when you least expect it. So yes. Tell us about how your app is going. I know that you've been developing a really great tool for contact tracing in places like schools and other industry sectors at the Sierra Pacific Orthopedic Clinic.
Thank you for calling on me, as you do every once in a while. I appreciate it. I need to give some proper. I actually was swabbed Thursday at Community downtown in the morning in the tent, and they were great. I was in and out in a very short period of time. I thought it was a well-oiled machine. I had my results later that day, which obviously you see I'm back at work. So, but I must give credit to your staff. I can see why it serves an awful lot of people.
Thank you. Yeah, and you know, I worked on July 4th, and on the morning of July 5th, I had notifications on my phone, like, here are all your positive patients. And I was able to call them and really just, let them know what their diagnosis was, et cetera. So yeah, it actually is working pretty well. I mean, I have to give kudos to our hospital partners. They've really come a long way in a very short time trying to give tools to the doctors so that we can enhance communication and really facilitate the contact tracing.
Yeah, it went through my chart and it worked perfectly. I got the notification, I signed in, and there I was, not detected. Great. So it's perfect. As far as the app, thank you. We had a new development, a build came out today. So we are officially in the Google Play Store. Officially, we have changed a couple of the registration things. The contact tracing part is working. I actually went through the whole process with it, obviously on Thursday, and we had some staff members. Here we're using it at SPOC, all 225 employees. IQ is about to come on, from what I understand. Fresno State Athletics, not on campus, but athletics is going to use it. They got pushed back a little bit. So it's actually working. We're getting a little bit more, we're getting an awful lot of information, or a lot of info is being given and being requested by the school districts. And so Mr. Iovino and some of the board of supervisors, like Mr. Magsig, have reached out and are actively looking and searching at this, as are some of the retail places like restaurants, to try and get ahead of and stay open. I think that, and Dr. Favora, I think that a lot of the perception is that the county kind of got put on the naughty list a little bit, and trying not to be grounded and have things closed, and God forbid even take away the allowance. But I think that there's some people that are really trying to get in front of it, and that's kind of a simple way to put it. But
great.
And so we're very lucky. I think we have some promising stuff with the county, as you know, and some of the IT directors there, to see how we can get this to the masses, to the underserved, and make it available. And that's really kind of how this whole project started from day one, 3.5 months ago, is how do we get this to a critical mass and to people that don't have it. And I think we have some of those problems solved. So
And you and your team kind of started from scratch. I mean, you and Jeremy just really just saw a need and really pursued it very aggressively and built this from the ground up.
The quick story behind it is we started screening here at SPOC, I think on the 16th or 17th of March, along with some of the other community partners like IQ and CCFMG had started. And after about 2 or 3 days, it was a Friday night, I got a text and Jeremy said, and our CEO called me and said, hey, thank you for getting this up and running. You're screening 1,000 people a day at the office and you don't even know it. I said, I wonder if we can make an app for this. And then a couple of the IT guys go, what did you just say? And next thing you know, I was that crazy scientist that had to wake up in the middle of the night and write stuff down and send a text to our developers in India. And 8 o'clock every morning, a new build comes out. So this is really how it started.
Wow, that's really fantastic.
So we'll see. Hopefully it's a tool that we can use and we could use across the board because that's really what it's designed for. And it's simple.
That's great. I wish you continued success and feel free to keep us posted or if you want to.
We will. Yeah, we will.
I know you have videos and websites and stuff like that. So
we have all that stuff. If there's information for the public or for business leaders that are looking for something, some of the packing houses, just feel free to reach out. And I appreciate your support. I mean, you've heard about it from day one. I've been bothering you with it since day one, but
no, it's fantastic. What is the app called again? Like if we're looking at
it's Vera Health. It's VeraHealth. It's all one word. And you search for it in the Apple Store or in Google Play.
All right. You heard it here, folks. Vera Health. Is that what I heard?
Well, that's going to be version 2. That'll come out right before influenza season. Vera Health. Then you can retire as interim. Take the interim tag off, and you're done. That's the goal.
Vera Health. VERA Health. Look for it. If you have any questions, these amazing clinical geniuses at SPOC are happy to help. They're our contact tracing street team. So thank you so much, Richard. I really appreciate it.
Thank you. I appreciate it.
Jeremy as well.
Dr. Vora, I have one last question. I'm sorry about that. I just got an email from one of our editors, and I'd like to get your sense. Do we have enough contact tracers? You sort of referenced that when you talked about trying to get the recovery rates, but do we have enough contact tracers in this county to do what we need to do, or are we falling short?
We don't currently have enough, but I think that we'll get there. And I say that with a little bit of hope because we've been able to hire up, a few dozen here with the Department of Public Health. I think I announced a couple of weeks ago that the state was actually deploying 20 contact tracers just through mechanisms that they've set up. And outside of that, we've been able to hire from our local resources and really involve places like our local schools and the nurses at our schools. We want to get them trained to be contact tracers. And beyond that, we're really planning to work hard with partners in our rural communities that are really advocating for our farm workers, as well as our community-based organizations that are working within the city of Fresno. And all of those groups are really going to represent the new wave of contact tracers that we want to set up. I think that this is a smart move because it will really lead to, I think, a decentralized network that is, embedded and familiar with the populations that we need to serve, and hopefully will give us really good, rich feedback about what we need to do to actually make contact tracing work. On one level, contact tracing is simply just a game of freeze tag. It's really just calling someone on the phone and saying, you've got coronavirus, or you've been close contacts with someone who's got coronavirus, and you just need to sit out until this period of quarantine is over. So that's kind of the easy method of doing it. But what we found out is that there really is a need for a lot of what we call wraparound services to really make sure that this freeze tag works. And that's just because people have to get out. They have to have their needs met in terms of their medical needs, sometimes their childcare, sometimes their work, and sometimes they just need really basic necessities of life. And so that, I think, is what really challenges the ability to do the quarantine, the isolation that we are recommending that people do. And that's really where we need the community organizations, the advocates, people that really understand what people are going through, really at a really intimate level, in order to solve these problems. And we've come to that humble observation the hard way, is because, you know, we really started out, I think, with good intentions, but really just with template orders that we would just mail to people. You can also find them on our website. And even though those are the orders on the books, when the rubber hits the road, it's really a much more informal, a softer skill that's required, because it's not just serving somebody a legal order and then they comply 100%. It's really working with them to figure out, you know, how can we help you? How can we support you? How can we protect you at the same time that we're protecting the rest of the community? And that's where contact tracing becomes much more of a skill set, instead of just a phone call. And it requires, like I said, a deep understanding of what that person's going through, what are the unique aspects of their life that we really have to understand, and really how can we prevent this epidemic from spreading into our vulnerable populations in the future, really picking up on trends, and observing things before they happen, to figure out, like, okay, we just need to, you know, it happened to this person and there's hundreds of other people that are going through the same life experience and live in the same way. So how can we actually prevent this from happening to all those hundreds of other people? You know, sometimes it's a matter of figuring out how a person commutes, you know, and they may work at a place, and they can certainly get time off from that workplace. But it turns out that there's hundreds of other people that are commuting from one town into another, sometimes even into another county, and they're all commuting together. And so how do we actually protect all of them while they're commuting? These are the kinds of questions that we have to answer. And that's really what the contact tracers have to figure out. They have to be detectives, to figure out how this pandemic, how this disease is going to be spread from person to person, and then really interrupt that cycle of transmission by asking hard questions and making some astute observations. So that's where I think contact tracing will need to go. I'm really hopeful that by recruiting contact tracers who understand how people live and where they live will really help us expand and really succeed in ways that we haven't yet done, as we expand our contact tracing efforts here through the county.
Thank you very much. I appreciate us.
We're at about 80 contact tracers here at the department, and we're hoping to get to 200 to 300 before we're finished training people up. So we know that we have more work to do, but just like with the testing, you know, we're going to keep plugging away at it until we see the numbers where we need to see them.
Fantastic. I appreciate being able to ask you a question, hand you the ball, and let you run with it. Thank you very much.
Oh. Thank you.
Before you sign off, can I just ask you a follow-up question to that about contact tracing? Does that, a lot of the counties in this Central Valley have a lot higher recovery rate than Fresno County does? Is that because we're still short on the contact tracers?
Yeah, I think that's part of it. You know, I think as Liz asked earlier, I think the way that we're counting recoveries has to do with some of the phone calls that we're making, and those don't necessarily always close the loop. So I think that that's part of it. But yeah, I think that, you know, as we get more contact tracing done, and as we try to, you know, I think advance our technical ability to reach out to people using things like the apps that Richard just described, the websites, maybe, you know, email-based conversations as opposed to just telephone-based conversations. I think we need to meet people where they are, and they're not always on the phone. In fact, they're rarely on the phone whenever we're trying to call them and really give them good information. So there's many times when we just have to try multiple times before we just give up and say, this person can't be reached. And all of that requires personnel. And that's where the contact tracing numbers really challenge us, is we don't have enough personnel at this time, especially in the last 10 days. The numbers have just kind of grown by such degrees that it's really hard for us to keep up with contact tracing at this time. Some counties have just stopped. We're not there yet. I hope that we'll never get there, but some counties are just, they basically have everything posted on a website, and there's just a statewide order, not a statewide, a countywide order, to where they've just told their residents that they're not going to do contact tracing anymore because they don't have the resources. And they really are, moving away from this model of intensive contact tracing where you have one person assigned to a case and they really try to work through all of the different challenges that that person or that family has. We're really not at that point, and I hope that we don't get there. I hope that we actually go in the opposite direction where we're able to deploy a lot more resources to help families. I do think that that's the right move to make to support our community. And I feel like we do have good plans in place and good partners that will help us get there.
Thank you.
You're welcome. I think we'll stop there if that's okay with everyone. And we will do an update on Wednesday at 4 p.m. So please keep reaching out with your questions, and I really appreciate your time.